Hello, my name is Gabriel Quesada from El Salvador. We're going to talk about the long-term follow-up of the small aperture IOLs. The purpose is to report a 2-year follow-up with the small aperture IOL to treat presbyopia concurrent with cataract surgery. This is a non-masked, non-randomized retrospective case control study of 3 different groups of consecutive patients in a private practice in El Salvador. Group number 1, small aperture IOL in the non-dominant eye and a monofocal IOL on the dominant eye. Group number 2 were small apertures IOL bilateral, and group number 3, small aperture IOL in irregular corneas. As you can see, the group 1 mean uncorrected visual acuity in 40 eyes of 40 patients was 20/23 for distance, 20/24 for intermediate, and 20/30 for near. In the group 2 with bilateral implantation of the small aperture IOLs, we have a distance vision of 20/23, intermediate vision of 20/24, and near vision of 20/30. This is a comparative slide of the near vision, intermediate, and distance vision from the small aperture IOLs and the monofocal IOLs. And you can see that it goes much better when the implantation is bilateral. This is just an example of how you can easily see the retina even through the mask of the small aperture IOL. And after 2 years, we did have posterior capsular opacification. We have 3 cases, and the JAG laser can be done easily with no problems at all, and you can see that the mask is respect and the optic of the IOL is perfectly clear after the JAG application. So as a result, we would say that in the third group, small aperture IOLs for irregular corneas, 7 radial keratotomy patients, the topography SIM-K was 30.9 plus minus 2 diopters. They had around 13 plus minus 2 radial cuts per eye. All patients had a significant decrease in their self-reported symptoms of glare and halos, but the uncorrected visual acuity was stable through the postoperative to 20/30 at distance, 20/30 intermediate, and 20/40 at near. This is one example of the topography of those patients and the retina images through the small aperture IOL in a radial keratotomy patient. In conclusion, we would say that patients with bilateral masked small aperture IOL demonstrated excellent monocular and binocular unaided vision with minimal adverse subjective symptoms. Complex group 3, the post-radial keratotomy and irregular corneas, the small aperture IOL result in excellent unaided vision and increase in depth of focus. In all cases, the mask in the small aperture IOL allowed good imaging of the posterior segment. Different instruction for posterior segment examination with the small aperture IOLs are not required, and JAG laser capsulotomy can be performed as with any IOLs. Thank you very much.